Hey guys, so today we're going to be talking about anxiolytics, anxiety, and related disorders. When we're looking at our objectives for the lecture today, these are what we're going to talk about. And I'm going to break this up into a number of different videos. So the first section we're going to be looking at is identifying symptomatology with generalized anxiety disorder, panic disorder, obsessive compulsive disorder, as well as post-traumatic stress disorder, and how to basically diagnose those conditions. We're also going to spend a little bit of time talking about pathophysiology of anxiety and its related disorders, and then describe some of the pharmacotherapy in the treatment of patients that are experiencing anxiety or related disorders. So if we're looking at a little bit of background about anxiety, as a whole, anxiety is the most commonly occurring type of psychiatric disorder. So if you take the prevalence altogether of these slightly different disease states, it is more common than major depressive disorder. However, alone, major depressive disorder is more common than, say, social anxiety. If we're looking at percentages, the most common type of anxiety disorder is going to be a social anxiety, followed closely by generalized anxiety and panic. And then things like post-traumatic stress disorder and obsessive compulsive disorder are a little bit less common, so 1 and 3.5%. There are about 40 million adults in the United States that currently have a diagnosis of some sort of anxiety or related disorder. So when we're looking at epidemiology, it's more commonly associated with females versus males. And what's interesting about anxiety is it is characterized by periods where patients can have long times where they're remitted of symptoms and not really experiencing any anxiety-related symptoms, and then periods of intense exacerbation. So it's kind of a chronic cycling type disease versus some of our other illnesses, which can have singular periods of experiencing symptomatology or a chronic degrading type nature, such as with schizophrenia. We're looking at mean age of onset. In general, it's a little bit younger than some of our other disease states. So we do have a number of patients that get diagnosed with anxiety that are preteens into early 20s. We do see some in the middle adulthood, and we do see a large proportion of patients who have other mental illness comorbidities. So as much as 90% have had some sort of other mental illness diagnosed, whether it be bipolar disorder or depression, etc. So anxiety is kind of an interesting disease state to think about because it's also a protective mechanism, right? So when we experience anxiety, it's really an emotional state that is triggered from the perception of either real or the potential for dangerousness that can happen. So when we feel a threat to our security or our safety, we then kick into a fight or flight type response. And that allows us to prepare for those environmental changes to help kind of save our skin. So the question really is, when do we consider anxiety a disorder? So when is it problematic for individuals to experience this fight or flight response? So there are a number of disease states that I wanted to quickly touch base upon that are related to anxiety. So the most common one you probably think of is generalized anxiety disorder. And through the DSM-5 criteria, we can see here that generalized anxiety disorder is associated with feelings of anxiety or worry with a number of symptomatologies on top of it. So because it's generalized, it should not be over a singular topic. So if someone's only worried about spiders, or if they're only worried about having panic attacks, that's a different type of disease state to explore. This should be in a number of areas of their functioning. Patients can experience at least 3 of the following: restlessness or feeling keyed up, being easily fatigued, difficulty concentrating, irritability, tension in the muscles, and disturbances of sleep. And this should be about 6 months or more for a number of different activities, with individuals having a hard time controlling their anxiety. So coping skills, if they have any, aren't really working. They're really focused on the worry that they're experiencing. And they should be focused on that worry that they're experiencing to the point where it's causing what we consider clinically significant functional impairment. So really that's one of our key components of diagnosing patients with mental illness, is when they have that impairment in their ability to function socially, occupationally, etc. We always want to rule out those substances or medical conditions that can mimic anxiety. And we just want to think about other mental illnesses as well that may be contributing to the clinical picture. If we're looking at social anxiety is a little bit different because it's much more specific to a scenario. So the individual with social anxiety will have a marked experience of fear or anxiety as it surrounds social situations, particularly if there's a level of scrutiny that may be accompanied by that social situation. So, for example, presenting to a large group of people or being the object of attention at a party would be examples of places where someone with social anxiety would experience that fear. Individuals will fear that they will act in a way that will be evaluated by others in a negative way. So they feel as if they're going to make a fool of themselves or act goofy, and people won't like them, essentially. So those social situations that some people really enjoy will really provoke a lot of fear and sensations of anxiety in those patients. And it's really a level of fear that's out of proportion to the actual threat of the situation. So sure, we get stressed when we talk in front of people. It's one of the biggest fears that we have. But when it becomes to the point where an individual has a really hard time enjoying a social life, that can be problematic. And that's where that clinically significant distress or functional impairment starts to come in. Same idea that we think about when it comes to substances and medical conditions and other mental illnesses. We do have some specifiers for this illness, so if it's performance only or if it's selective mutism, so if some individuals in social situations will have difficulty speaking to other people. We see it in film, but it is actually truly an experience that some people do have. If we're looking at panic disorder is basically the experiencing of panic attacks and then fear regarding having more panic attacks. So what this really means is one can have panic attacks without experiencing panic disorder. So those can be somewhat exclusive of one another. Of course, you do have to have experienced at least one panic attack to be diagnosed with panic disorder. So panic attack is defined as an abrupt surge of discomfort or fear, and it occurs within minutes. Typically, it'll peak very quickly and will go away within about an hour. Patients and people in general can't tolerate the intense experience of a panic attack for much more than that. So some people will misinterpret generalized feelings of anxiety with what they might consider to be a panic attack. If you've ever experienced one, you probably know what I'm talking about. So the symptoms that we see with panic attack are listed here. So at least 4 of these would be diagnosable. So heart palpitation, so feeling like your heart is pounding out of your chest or very quickly. Feelings of sweating, becoming trembly or shaky, shortness of air, so that's what SOA means, or the sensation that you're being smothered or choking. There can be experiences of abdominal distress or nausea, direct chest pain or discomfort, and a lot of patients will actually go to the emergency room thinking that they are having a cardiac or heart event, where they're actually diagnosed with anxiety because their actual physical heart is not in any sort of illness situation. It's actually the physical manifestation of this intense experience of anxiety. Patients can also feel dizzy or lightheaded. They can have chills or hot flashes, changes in their sensory, so tingling is oftentimes experienced by patients during a panic attack. The sensation of derealization or depersonalization, so feeling as if you are not in a reality or you're out of your body. And then fears of doing things such as losing control or fear of dying. So it has to be a recurrence of unexpected panic attacks for someone to be diagnosable for panic disorder. And they really have to worry about that attack for at least a month for it to be considered problematic. Most patients that experience panic attacks will develop these coping skills that are actually not helpful for them. So we consider them to be what we call maladaptive changes, so avoiding situations with which they might endure a panic attack, essentially. And this can progress to what we traditionally call agoraphobia, where patients will actually essentially not be able to leave the cozy environment of their home for fear of things like open spaces or crowds or just uncomfortable situations, which may to them induce panic attacks. Same rule outs that we have for other conditions, so substances, medical conditions, and other mental illnesses. Now, one that's talked about a lot, but relatively uncommon, is obsessive compulsive disorder. I'm going to assume that you are all somewhat familiar with obsessive compulsive disorder, as well as obsessive compulsive personality, which is a common misnomer that people use just because they are particular about certain things. So obsessive compulsive disorder itself can be very debilitating for patients. So it can be a very, very severe illness that takes up a large proportion of their time in the day and causes them a lot of distress. Patients with obsessive compulsive disorder have these two components to their illness. So obsessions and compulsions, which makes sense. So obsessions are the thoughts that are associated with the anxiety. So they tend to be intrusive and unwanted and unable to be ignored. So thoughts that your mom's going to get hurt or that you're going to get hurt or something bad's going to happen, and it's intrusive, right? So what the patient with OCD or obsessive compulsive disorder will do to try to manage those obsessions is to create behaviors as a kind of anxiety reducing or distracting event to manage those obsessive thoughts. So what we see are what we think of as repetitive behaviors or mental tasks that the individual feels very driven to perform. Now, most patients with OCD have what we think of as good insight into their illness. So they realize that what they're doing is not actually related to what their anxious obsession is about, but they're still unable to stop those behaviors. So tapping, counting, washing, checking, all of those things are what we typically consider a compulsive activity in patients with obsessive compulsive disorder. Now, I'm sure a lot of us have checked our ovens more than once or twice. If we're not certain about it, it's really once it becomes time-consuming or significantly interferes with someone's ability to function. So if they're spending hours every day checking doorknobs, that's where we see this issue start to come up, right? So patients will be very debilitated because they will be spending most of their day performing these ritualistic acts to help with their anxiety. The same rule outs apply for obsessive compulsive disorder than what we saw with our other mental illnesses. Finally, I want to talk a little bit about post-traumatic stress disorder, or PTSD. So this is not considered an anxiety disorder anymore, but is related and is treated somewhat similarly. So I wanted to talk about it here. So PTSD can be diagnosed once a patient or an individual has been exposed to some sort of threat. So it's a threat of death, injury, or violence. So most patients will have direct or witnessed experience, but in the most recent iteration of the DSM-5, we do have the caveat that they can be exposed to the details of the event, somewhat like what we would see with the September 11th attacks. So the exposure has to have happened about a month ago and be characterized by behavioral symptoms. So we have these diagnostic clusters that we see patients experience. Common one we think of is our re-experiencing, so that idea of flashbacks or recurrent memories of the event. Avoidance, so persistently avoiding external reminders or distressing memories, so trying to block them out or avoid places that might trigger you to remember. Negative cognition and mood, so they may forget what happened during the event or have very strange or unpleasant feelings towards the event. And then arousal, or what I like to think of as hypervigilance. So you see this a lot with like patients who are combat-related PTSD, where they always look like they're looking over their shoulder and very concerned about their environment, very hyper aware of what's going on. And this can lead to things like sleep disturbances because they're fearful of not having that vigilance when they're asleep, as well as things like aggression. So this can be very problematic for patients.